All right, so to give you a little bit of background, the hospital was established in Amman early 2006, initially for Iraqi patients, later for other nationalities in the Middle East. Now, the hospital provides reconstructive surgery for three main types of patients. Those with orthopedic injuries, those with the plastic surgery patients with burn-related injuries, and the localized injuries of the maxillofacial area. The patients are first identified in their country of residence and through a network of medical liaison officers. And if they are approved by the RSP committee, they then transferred to Amman for further consultation and preoperative care before they are hospitalized in one stage or more. Now, this was the first study to be conducted on all the patients admitted at the hospital since its inception until the end of 2016. It's basically a retrospective analysis of the routinely collected data to describe the demographic, the diagnosis, and the certain outcomes regarding the duration of hospitalization. So in order to create the database for this study, we had to map all the data at different departments at the hospital, looking into tens of data sheets and thousands of records. And we ended up having a total number of 8,242 medical files, which were reviewed by the committee, out of which 54% were approved and admitted to the hospital. And in total, we were able to analyze 3,015 patients. So in this graph, you see that during the first 5 years, it was exclusively for Iraqi patients. And since 2011, the RSP opened its door for other nationalities, mainly Syrians and Yemenis and those affected by war. So you see the peak was recorded in 2012, where the needs among Syrians were remarkably high. And we would expect the same during 2014 and 2015 following the Mosul conflict, but the RSP faced a lot of operational and difficulties in bringing these patients to Amman. And in 2016, just after the war started in Yemen, we started having more of Yemeni patients. So in this table, I'm showing you some characteristics of the RSP patients by nationalities, where you see that predominantly more than 80% of the patients were males, and the majority of them were above the age of 25 years old. Now, patients reported different causes of injury, and we saw that the Iraqis and Syrians were mainly victims of blasts, whereas Yemenis were more gunshot victims. We also measured the waiting time after validation, and we saw that it was around 1.5 months, but Syrians were admitted much faster than others, and this is due to the fact that they were recruited in Jordan, not in their country. And also, we saw that the length of stay for the patients during one admission was around 3.2 months. In this table, we also show that patients reported the median waiting time for patients to get admitted after validation was also different, and it was also based on speciality, where plastic patients, for instance, had to wait much longer than the rest. And similarly, we also investigated the differences between specialities, where we found another interesting finding that a substantial number of patients with gunshot wounds were admitted to the maxillofacial department. So we also calculated the median time until the patients exited the program completely after receiving their full treatment at the RSP, and we found that the duration was significantly different between different specialities, where orthopedic patients had to stay much longer. Now, briefly on the diagnosis, there were 46 different types of diagnosis, with the most frequent presented in the table following this one. So given that the majority were in need for more than one surgery per admission during 10 years, the hospital conducted over 7,000 surgeries, which consisted of 11,000 surgical acts. So here you see the most frequent diagnosis. And a major proportion of patients were treated for non-union of fracture, and clearly each type of diagnosis was treated differently with different surgical acts. As you see in these examples, this also had directly affected the length of stay at the hospital. So you see that patients with chronic osteomyelitis had to stay significantly longer than other cases. Now, another challenging aspect of the treatment was the presentation of high infection rates among orthopedic patients and the prevalence of antibiotic resistance. And this would be further presented in the following presentation. So after discharge, the RSP conducted over 8,000 follow-ups on this cohort to assess the presence of complications or to determine if these patients can exit the program or to be readmitted again for another stage. Accordingly, in this cohort, we had 36% of the patients, exited the program, and 1/3 were to be readmitted for subsequent stages, and around 9% were still under follow-up, especially those in the last 2 years in the cohort. And the rest were defaulters, referrals, or refusals. So in conclusion, I believe that the results presented today reflect somehow the complexity of managing this program on both operational and medical levels. Undeniably, the need for reconstructive surgery is still on the rise in the Middle East, but there is scarcity of evidence on the optimal provision of such care. It would be useful also to understand this care from patients' perceptions, and this was recently done through an anthropological study that gave more insights into from patients' perspective. The RSP also has been continuously looking to further improve its quality of care and expand its capacity towards a patient-centered approach. Some recent example as the implementation of the electronic medical record and the work to facilitate access to patients in Gaza. Now, the study required an extensive team effort, and I would like to thank everyone who contributed to this study. Thank you.